My name is Christian Sousa Reed. I am a co-author in this work. We want to thank to the patient and his family for their collaboration and support to this work. In this article, we present a case of a male patient, 38 years old at the moment of diagnosis. He was treated at our institution in Chile, Fundación Arturo López Pérez. The patient was diagnosed with metastatic colon cancer. The molecular analysis of the biopsy showed deletions in two genes, EPCAM and MSH2. MSH2 encodes an essential DNA mismatch repair protein. Germline mutations in DNA mismatch repair genes and microsatellite instability are clear signature of Lynch Syndrome. Initially, we treated the patient with 12 cycles of FOLFOX. However, at the end of the treatment, a detailed PET-CT scan showed that the disease was still progressing, and even a new lesion appears at the level of the 11th right dorsal vertebra, as shown in the picture by the white arrowheads. Tumor with deficiencies in the DNA mismatch repair system leads to a high mutational load in the cell, and as a consequence, produced a high infiltration of lymphocyte in the tumor microenvironment. The tumor cells highly express PD-L1 ligand, inhibiting T-cell immune response. By using an antibody against PD-1 in T-cells, we can reactivate immune response. Therefore, we treated the patient with an immunotherapy scheme of 12 cycles with Pembrolizumab. After 4 cycles with the immunotherapy scheme, the patient's symptoms improved, and we observed a reduction in the metabolic activity of the tumor lesions. Although the tumor were still present by the end of the immunotherapy cycles, this treatment was capable of delaying a second-line treatment for at least 8 months. It is well documented that Lynch syndrome colon cancer patients benefit from immunotherapy. However, this is not a standard procedure in South American countries. We want to highlight the importance of including these patients in immunotherapy treatment programs in the future.